So what we're going to talk about today is sepsis and why we care about it. So all this stuff came out with these criteria, and we're supposed to follow them. But why are we supposed to follow them? And I think the most important thing to talk about with sepsis is the fact that a lot of people think when people are septic that they're bacteremic. So it's all bacteria, and that's not what sepsis is about. Usually it is bacteria, but you can have viruses that cause it. Sepsis is actually the body's response to infection. And so there are people that are young that get viral infections and they are septic from their viral infection because it's a state of inflammation. So that's how you have to think of it. And that's why you do all these sort of strange tests to measure it, because you're actually looking at what's the body's total inflammation. So if we just go through these criteria, we'll just run through them real quick. So the CMS has defined it as two different things, and these are based on the CMS criteria, which are based on some articles that were done at Henry Ford Hospital. So they break it down to severe sepsis and septic shock. In terms of severe sepsis, one, you have to have some sort of documentation that there's an infection somewhere, because other things can present like sepsis if you're bleeding and losing blood. If you have a heart attack, some neurologic conditions can present like this. So first of all, you need some sort of infection or thought that there's an infection going on. And then we have these SIRS criteria. Is that blurry? Make it a little better. There you go. So the SIRS criteria, that's just sort of systemic inflammation. And so you're looking for an elevated temperature or a low temperature. So the low temperature is important too, because the people with low temperatures are much more likely to have to get very sick. And so when we're doing the sort of forehead scanning temperatures and they're low, documenting that temperature, that's like actually worse than if they had a fever. So we really need to be careful about what we document in terms of those temperatures. The mortality right now in terms of people with a fever and sepsis is around 30%. If they're hypothermic and septic, the mortality is something like 71%, and that's from numbers about 10 years ago. So it makes a big difference. If they have an elevated heart rate, if they're breathing fast, if their white blood cell count is high or it's really low, or they have a lot of bands. And what the bands are, they're just sort of a immature reactive kind of white blood cell. And then we're looking for, on top of that, some sort of organ dysfunction. So either they have a low blood pressure, they have new renal failure, so these all need to be new renal failure, new liver failure, platelets that are like platelet dysfunction, their INR is elevated if they're not on Coumadin, which also goes towards sort of organ dysfunction and liver dysfunction, or if their lactic acid is elevated. Now, if the provider documents somewhere the patient's septic, that counts too. So, and then if we go to the septic shock, this is the same. All of those other criteria that severe sepsis is present, and then also some sort of hypoperfusion, and this could be after IV fluids. If their blood pressure is just generally low, like they have a very low blood pressure and it's not responsive to a small fluid challenge, then they're considered to be in septic shock. And this is generally most of the people that you think of as the really, really sick septic patients. So the criteria we use for this is a systolic blood pressure that is less than 90, and then or MAP that's less than 65, and then an elevated lactate that's above 4. And the lactate just sort of shows total organ perfusion. So no matter what their blood pressure is, if their lactate is really high, then they're considered to be in septic shock. So any questions about the sort of criteria? They're listed out. There's multiple checklists and everything else that will have them listed to sort of go through them. But mainly, if they're hypothermic or they have a fever and then their vital signs look unstable, then you have to consider them being septic. So So that's sort of the way CMS wants us to look at it. Now let's talk about sort of why those things happen. So all of this occurs as an inflammatory state at the cellular level. So if we look at what's going on, and so this is a little biochem slide. So there's two ways that your body sort of addresses injury or inflammation. So this first pathway up here is a bacteria virus comes in, it gets eaten by these macrophages, and there's a couple other cells that do that, and they sort of stick pieces of the molecule out on the outside, and then your body says whether this is something that's supposed to be there or not there. And there's certain compounds that stimulate a very aggressive inflammatory response. There's especially on bacteria, something called LPS is on a lot of the bacteria, and that will stimulate this big immune response. And then this PAMPs thing, that's just a pathogen-associated molecular pathway. So that's all the things that sort of ramp up the immune system. And what happens in that is you get these cytokines released. So those are all the things that ramp up the immune system, cause inflammation, cause all the other parts of the immune system to become activated, and then complement works with that. And then all of those, in addition, will cause the leukocytes, so those are the white blood cells, to start attaching to where the inflammatory process is occurring. And so you can go through this pathway and you can get this to happen. The other thing that can happen is if there's tissue damage, you can have damage-associated molecular pathways, so that's the same sort of thing, that also do the exact same thing. So you get a twofold problem here with infection. You have bacteria that comes in and sort of automatically stimulates your immune system, and then it injures tissue, which then stimulates the immune system even more. And so this can turn into a vicious cycle. As the tissue's damaged, you keep getting more and more of these compounds released. And what happens at a cellular level is it hurts the endothelium. So the major player in all of sepsis and all of most injury where people become really sick is that there's an endothelial injury. So it's at the microvascular level. So the blood vessels get injured, and then it causes dysfunction, because that's the interface between the blood and the tissues, and that's where most things happen. So you get a couple things that happen. One, the vasculature gets really leaky. So it causes the blood vessels to dilate, things leak through, so you get less perfusion to that area. You get additional inflammatory markers that are released because now you have an injury to the endothelium, and so it goes back through here and encourages this. And you also get a hypercoagulable state. So how you can think about this is you think about it when you get infections all the time, and your body does a really good job of getting rid of them. So you think of like a small pimple that pops up. You get some redness around it. The body causes swelling around that. It decreases the blood flow to it. It walls it off. The infection's contained in a small space. It either gets the edema pushes whatever purulent material is out of that area, and then you sort of move on and you're fine. The same thing happens during this pathway, this damage-associated pathway. So say you get a splinter in there, you get lots of inflammation, it gets red, your body walls it off so no infection can spread or anything like that. And then as soon as you take the splinter out, within a few hours, the redness goes away and you don't have any pain or any swelling. And so your body generally does this all the time and it's fine. In sepsis, what happens is this endothelial injury gets out of hand. So it's occurring everywhere. And so if you're walling off all areas or all tissues, then you're going to get pretty sick. So if we look at that this way, so this is your healthy endothelium. So this is the blood vessel in here. This is the lining of the blood vessel, and this is all the tissue that's on the outside. And so you have your red blood cells, which are floating through. You have some protein molecules. You have some platelets that aren't activated. And then what you have is you have this thing called the glycocalyx, which is a layer of proteins and sugars that sort of coat your endothelium. And so the blood vessels have this coating, and it's all the way around. And what it does is it protects. You can almost think of the lining of the blood vessel without this blue layer on there, without that glycocalyc layer, as almost like Velcro. Things want to stick to it. What this does is it's coating that area. It's keeping all the sticky molecules from being able to interact with the blood. This is full of heparin and other molecules to stop clotting, and so it protects the interface between the blood and the cells that line those blood vessel walls. And so in a normal blood vessel, the blood is able to just move through. There's this non-sticky layer there, and there's no injury or anything like that can occur because nothing can sort of get to where the endothelium is. Now, in tissue injury, what happens is these cytokines actually cause your body to break down this glycocalyc layer. And so now you have all these, so you can, once again, think of it as Velcro. You have this Velcro layer there that things can attach to. And so all of the white blood cells and things that are part of the immune response will start attaching because they say, hey, this area is injured. We need to repair this area, or we need to stop what's going on here. And so what happens is the white blood cells start attaching and destroying the endothelium and breaking it down. It breaks down the junctions sort of between the cells because your infection is not in the blood vessel. The infection is in the tissues around the blood vessel. So you have to break apart these endothelial cells so that the white blood cells, which are in the bloodstream, can get into the tissues. But the problem is once you break down that, the protein starts to move over, fluid starts to move over, and that causes lots of swelling. It pulls the fluid from inside the blood vessels to outside the blood vessels. It also gets rid of. Remember, this glycocalyc layer is actually stopping clotting from happening. So it makes it so that your heparin that you produce is within that. Once that goes away, then you start forming clots along this, which is good because it traps bacteria. The white blood cells can get in there. It stops the bacteria from being able to move out into the rest of the body. But this causes clotting to happen. And so your platelets get activated. There's a couple of molecules on the actual endothelial cells that will grab the platelets and attach them there. You start forming clots within these blood vessels. And these aren't big clots. These are in the very small microvasculature. And once again, this is fine if it's occurring in a very localized area, but if it starts to occur everywhere, then that causes problems. The other thing you get release of reactive oxygen species. So the mitochondria release there's mitochondrial dysfunction, and they release all these reactive oxygen species, which end up damaging the cells around the area. You release nitric oxide, which causes all the blood vessels to dilate to try and get more sort of everything sort of to that area. And if this starts to occur everywhere, then all the blood vessels dilate, and you tend to get more and more sick. So I know there's a lot of stuff going on here, but basically you have to think of it as you're forming clots. Your blood vessels are getting really leaky because they're not protected anymore. And, the white blood cells are trying to move into the tissues, but at the same time, the tissues are being damaged. And you would think, well, why would your body want to do this? And it's because, before we had antibiotics, this was the last-ditch effort. Like, it's sort of like you have, if somebody has a gangrenous leg, and the step before antibiotics was you just cut that off and get rid of it. And that's what your body's trying to do. So it's trying to just cut off whatever the problem area is to save the rest of the system. The problem is it causes inflammation everywhere, and then you just you have generalized organ dysfunction. So if we look, and this is a pretty generic slide, but if we look at what happens, in your brain, you'll get confusion, you get delirium, you're not with it, just because you have injury to those, to sort of a global injury to the brain cells. In terms of your lungs, if they get leaky, you get fluid that will pool there, and this can lead to lung injury and acute respiratory distress syndrome. So the people that end up in the ICU, they may have so say they get a pneumonia that makes them fairly sick and they're septic, but then they have a continued lung problem, even though the bacteria is gone, but they can be in the ICU for months just because of all the damage that the inflammatory process that's associated with the bacterial infection caused. In terms of cardiovascular injury, most of that is caused by your mitochondria don't want to function right because of the injury. Your liver has decreased perfusion, and that can cause liver injury, and will also cause your lactate to go up because your liver is part of that process. People tend to be hyperglycemic because they get pancreatic dysfunction. Your kidneys don't function well because they're just not getting enough blood supply. And then you can have adrenal hemorrhage that's associated with it, just from stress on the adrenal glands. And then you can have where the person doesn't have enough cortisol around or things like that to sort of get their body to be able to sustain this or be able to function in this inflammatory state. So that's sort of the idea behind it. So it's a microvascular injury that then causes organ dysfunction. But it's really that breakdown of all of those little blood vessels that causes the problem. Any questions? No.
Can you also, I feel like I remember this and I might be making it up. Can you also get hypoglycemic from
You can.
sepsis?
Mm-hmm.
Okay.
Yeah, if your body sort of ramps up and is using up your glucose stores, and a lot of, so when you sleep you don't need to eat because you store your glucose as glycogen in your liver and everything else. And so if you have liver injury, you might not have that glycogen around to convert into glucose, or you might just be in such a ramped up state because you're using so much extra, metabolic energy that you don't have the sort of the reserves anymore. So what do we do about it? Well, we do a bunch of diagnostic tests, and we can sort of run through these so we know what we're doing and why. One goal is to figure out where the source is, and the other goal is to see if we have systemic dysfunction. So we get blood cultures, and we don't get blood cultures because bacteremia is causing us to be septic. So bacteria in the blood is causing us to be the way we are. There's a higher likelihood because those blood vessels are leaky. So white blood cells can go through, bacteria can go through too. So it works both ways. So the probability of having bacteria in your blood is a lot higher, but that does not necessarily mean that there is or that's what's causing the problem. And then you look at the urine and a chest X-ray, and then you get imaging to see if you can find a source of infection, whether it's in their abdomen or their chest. Things that often people don't necessarily think about are, is it in their spinal fluid? So meningitis can cause you to become septic. And then C. diff can cause you to become septic. So there's intestinal infections that can. So somebody has diarrhea, we want to really sort out whether that's causing it, because even though it's just diarrhea, you can be really sick from something like that. So in terms of systemic dysfunction, what are we looking at? We want to see how the liver's functioning, and so we get an INR because that should start to increase if the liver's not functioning well. And you can look at the hepatic enzymes. So somebody that's in septic shock, a lot of times their enzymes will be elevated because there's injury to the liver cells, and so that's why you'll see those increase. You look for cardiac dysfunction. So I know a couple people have asked, well, why are we getting a troponin in this person because they have a fever and they're sick? It's to actually look for cardiac dysfunction, because you can develop cardiomyopathies and things like that from infections, and so we want to make sure that's not going on, or at least know that we need to follow that. And then we get coagulation just to look for DIC. So as you're forming microscopic clots everywhere, you start using up all of your platelets, all your clotting factors. And then what happens is you go from a hypercoagulable state to a hypocoagulable state just because you don't have any more supplies around to form clots. And then people will start bleeding, they'll start using up their red blood cells, so they'll start getting anemic because they're forming clots everywhere and just sort of using up everything that's around. And you get renal dysfunction. Most of that's from poor perfusion. We measure that based on creatinine and whether they are urinating or not. So you want to keep giving people fluids until they actually start to urinate, or they have to go on some sort of dialysis. The lactic acid's a really good measure of organ perfusion. So if organs aren't being perfused, they go into an anaerobic state and they start producing lactic acid, and that builds up. Your liver is also partially responsible for clearing that, and so it's probably a combination of poor organ perfusion and liver function that lead to the elevated lactate. And then we want to make sure people aren't neutropenic, make sure they have enough white blood cells around to actually deal with the infection. And then what do we do? A lot of, oops. That one. So in septic shock, we wanna try and sort of fix people's hypotension, because if they're hypotensive, they're not getting blood flow to their organs. So there's a couple of reasons that people get hypotension. So the first is they don't have enough fluid within their blood cells, and so they could be hypervolemic, so they have too much fluid overall in their body, but because everything is leaky, it's all leaked out of their blood vessels. So even though they have like awful edema and everything else, their blood pressure is still really low. It's because the fluid's in the wrong place. It's outside, and you need to actually put more fluid back in. So even though it seems like a bad idea to give somebody that has all this swelling IV fluids, you really need to, because it's not in the right place. And so typically we want to resuscitate people with crystalloid fluids, normal saline or lactated ringers. You don't want to give them hypotonic fluids. If they're having diarrhea or they're really acidotic, lactated ringers is probably a better idea, but when studies have looked at which is better, it sort of comes out as a wash. It's just that the lactated ringers have some bicarb and other things in them that will sometimes, at least it makes people feel better. In terms of blood products, unless they have active bleeding going on, you're really not going to want to give them a bunch of blood products. Giving them other things to cause clotting if they're in DIC is not typically helpful, because they're just going to use them up. And so you have to actually stop whatever the infectious process is before you can try and correct any of that. So unless they're really anemic or actively bleeding, you're not going to give them blood. The other problem is, as we talked about, when those endothelial cells are injured, you get release of nitric oxide, which causes blood vessels to dilate. And if the blood vessel is, a lot of the reason you can maintain a blood pressure is because you have the smooth muscles squeeze the blood vessels and keep a vascular tone. And in sepsis, that doesn't happen. So what do we do about this? Well, we can either, so the tube is bigger now, so we can either put more in it and hopefully bring up the blood pressure, or we can give something to squeeze the blood vessels to bring up the blood pressure. So generally, you give fluids first, and if it doesn't work, then you give medications that cause the blood vessels or the muscles to squeeze and sort of try to override this nitric oxide process that's causing this dilation. And so usually we use dopamine, norepinephrine, or phenylephrine. They're all alpha-1 agonists, and will cause the blood, and will squeeze the blood vessels, and that should increase people's blood pressure. And you can be on more than one. And then the last part of it is the cardiac contractility. So the mitochondria get injured whenever there's an inflammatory process, and the heart doesn't beat as well. So if the pump's not working, it doesn't matter how much fluid you put in there. If it can't squeeze it around, your blood pressure is not going to go up. Fortunately, a lot of the pressors that we have do both. So they increase cardiac contractility, or at least increase the rate, and therefore increase the blood pressure that way as well. So the main vasopressors for this are norepinephrine, dopamine, and dobutamine. And then if that's not working and you can't fix the problem than some sort of mechanical assistance. So there was a patient last year that was young and had the flu, had influenza, and went into septic shock and was actually flown out and put on ECMO to try and sort of keep her organs perfused until her body could get rid of the viral infection. And so this is an alternative, and it's becoming more popular, although albeit very expensive.
And they do that at University of Maryland, right?
Hmm?
They do that just at
Maryland or Hopkins or any of the tertiary care centers, they'll do it. It's becoming. You have to have usually you have to have a cardiac team there because they need a perfusionist and everything else. But there's some community hospitals that are talking about doing it. It's just a matter of who you do that for and if it's actually beneficial or not.
Is Anne Arundel one of those community hospitals?
Probably not.
No,
Probably
okay.
not. You're talking about hundreds of thousands of dollars. So, and then I just want to touch on the antibiotics because everybody asks about, why are we giving this antibiotic versus that one? And so I listed some of the bacteria that can cause sepsis. There's a whole lot more than this. Over here we have our gram-positives, and those are gram-negatives. The main thing that we typically give for this is a beta-lactam, so that's like your penicillin derivatives or your cephalosporins. And so those two are in the middle. So Zosyn or cefepime are the ones that we typically will give. Ceftriaxone is in there as well. And the reason we give those first is because of the coverage. You can see it's usually that and vancomycin. You look at vancomycin, well, it covers our gram-positives really well, but doesn't do anything for gram-negatives. And the only benefit you get is you get MRSA with the vancomycin versus the beta-lactams, which get most things. And we pick Zosyn or cefepime mainly because they also get Pseudomonas. Ceftriaxone will not. It's not active against Pseudomonas. So the cefepime is a 4th generation cephalosporin, and ceftriaxone is a 3rd generation. So typically, we give these antibiotics first just because they have broader coverage, and then vancomycin. Levaquin is one of the iffy ones. It actually covers a lot of things and is a really good antibiotic. The problem is that everybody's given it to everybody for everything, and so there's resistance that pops up. It does cover a little bit of MRSA. It'll cover a little bit of Neisseria, which is meningitis. E. coli, there's a lot of resistance to. So we typically don't use that as a first-line agent, although it counts in septic shock as your first drug given. But typically we want to, if there's no penicillin or cephalosporin allergies, we want to start here, and then we can sort of add to it depending on what else is going on with the patient. And then, of course, in the C. diff case, in the septic C. diff case, you have to give Flagyl, which should take care of it, or oral vancomycin.
Question, just because I'm super duper visual back here, and maybe it's because I'm so far away that I can't see, but wait, what? Oh, so the Levaquin, the error that's pointed to the Neisseria and the MRSA.
They're lighter.
So they are lighter. Okay, so why?
Because for MRSA, it covers about, in Anne Arundel County, I guess, or at AAMC, this covers about 15% of MRSA cases will be susceptible to Levaquin. And the Neisseria, sometimes it works, sometimes it doesn't. It doesn't necessarily cross as well into the blood-brain barrier and everything, as well as, say, ceftriaxone or one of those. So it technically should cover those, but it's not what you want to give because you could miss some.
Okay.
So, because otherwise it looks really good.
Yeah.
Mm-hmm.
That's why I was wondering.
But there's a lot of resistance. So E. coli, I think, is 70%, and so it's just because it's been overused, it's not a good medication around here anymore.
So if they have the penicillin and cephalosporin allergies,
Mhm.
what do we give first?
So if they have that, then we're probably going to give something like Levaquin first, like a fluoroquinolone. And we'll add additional medications depending on where the source is to try and get better coverage because there's a lot more antibiotic choices than what's listed up here, like gentamicin and those kind of things. But those are in sort of specialized cases. Generally, most people are going to be able to take one of these two. If they're penicillin allergy, the cephalosporin cross-reactivity is like 10%. And if they're cephalosporin allergic, then you could give them one of the penims, like a carbapenem, and the cross-reactivity between, like the sensitivity between that and a cephalosporin is 10%. So generally, you can get them some sort of thing that's in that beta-lactam class, unless they have some really weird bug that actually breaks down those medications. And some of our patients, some of the people with the chronic UTIs will have something that breaks down beta-lactams, and then those drugs are useless. Then you get into some like tigecycline and those other ones. So that's my general overview.